This is Growth and Development of the Newborn and Infant from Kyle and Carmen's textbook, Essentials of Pediatric Nursing. So when we talk about growth and development, we're talking about growth, which is things that can be measured or weighed. So increase in physical size, weight, even enlargement of organs. When we talk about development, we're talking about gaining new skills and functions. So learning to sit, learning to walk, those sorts of things. When we talk about maturation, that's increased function of body systems or developmental skills. So as the systems become more effective at working and as the skills become more refined. So when we do our assessments, assessing newborns and infants for developmental milestones, this should be done every time we have an interaction with a child. Are they on track developmentally? Let's ask the parent if they're doing the skills they should be at their age, or elicit the skill or the response from the infant. Sometimes an infant won't do it for you, so it's fine to ask the parent. When we do developmental milestones, we base it off of a screening tool, and these are some of the common ones. I'd say Ages and Stages is the one that's very popular right now. When you look at these, what it says a child should be doing at a certain age, it's basing that on 75% of children can do it at that age. So if you had children and your kids were early on skills, you're going to look at these and say, oh my goodness, they're not sitting till 7 months? My kid did that at 5. Yes, 75% of children can sit at 7 months. Yeah. And if they can't, then we want to test them farther. It doesn't mean we've diagnosed a problem. It simply means we need more testing. It may be they're never given the opportunity to sit. They're never, held up in a sitting position. They're always in an infant, wrapped against the mother in some sort of a carrier. So it means further study is needed, not that there's a diagnosed problem. So, assessing growth and development for a preterm infant, we want to make sure we base it on the adjusted age, not the child's chronologic age. So the way we do that is we subtract how premature the baby was from their actual age, and that's the age we're going to use for looking on the growth charts and the developmental milestones assessment. So let's do that. A nurse is assessing the developmental milestones for a 7-month-old infant. This infant was born at 28 weeks gestation. What would the adjusted age be? So 28 weeks, we know the average pregnancy is 40 weeks. Well, that's 12 weeks early. There's roughly 4 weeks to a month, so 12 weeks is going to be 3 months. So we're going to subtract that 3 months from the actual age of 7 months, which means we expect this baby to be the size of and doing the skills of a 4-month-old. So let's see if that works. And yes, in fact, we did our math right. So for neonatal growth, and remember neonatal, we're talking about the first month of life. Infancy, we're talking about the first year of life. So we expect a baby to lose some weight after birth. They've got to now start staying warm. They've got to start doing all their own metabolism. That mom used to do all these things for them. So weight loss up to 10% is acceptable, but we do not want to see more than 10%. And we want that baby to return to their pre-birth weight I've always heard by 10 days. Our book says 10 to 14 days. When the baby starts gaining weight, we want to see them gain about an ounce a day, 30 grams per day. And we can tell a baby's getting enough breast milk or formula in by what comes out. So we're looking at the stools. That first day, they should have a stool that's tarry black, meconium. By the second day of life, we want to start seeing a little bit of green in there. And by the third day of life, we'd like to start seeing some little gold seeds. That means they're getting good intake. When we're assessing their growth, realize those first 6 months of life, the growth is tremendous. On average, a baby doubles their birth weight by 4 months of age. We're really not concerned as long as they double by 5 months, but on average it's 4 months. And they're going to increase length by 50% during that first year. So we'll say we had a really long baby who was 20 inches at birth. We want to see them gain half of that, so 10 more inches. So 20 plus 10, 30 inches by the time they're 12 months. Head circumference, on average, a baby gains 10 centimeters in that first year. So the average baby's head circumference is 35 centimeters at birth. By a year, we want to see it 45. And that one we're concerned with too much, just as much as we are too little. When we do plot these things, we plot them on the growth chart. You can see they're blue and pink for boy or girl. Males tend to weigh a little more at birth, and so their weight through that first year is a little bit more. At the bottom, you've got weight. At the top, you've got length. And then along that x-axis, you have age. So you find the right line for age, follow it up, find where the two lines meet. That point is where we would expect them to be. And then you follow that point out. So let's say, I don't know, we have a 9-month-old who weighs, what is this? Oh, a little over 18, or right about 18 kilos. So we follow that out here. This is the 50th percentile. Percentile means you take 100 kids that same age and line them up from whatever. Lightest to heaviest, shortest to tallest, whichever you're looking at, the smallest head to the biggest head. And where does that child fall? Well, they fall number 50, right smack in the middle, which is fine if they've been 50th percentile along. If they've been at the 90th percent, they were a huge baby, they come from huge parents, and they're starting to fall to a lower percentile, we're worried. So a single point isn't as important as following the trend. What are they doing as a trend? So when we look at the infant for system maturation, we'll look at respiratory and cardiac separately, but neurologically, their brain, it's growing in size and also myelination. The myelination is happening on the neurons, and they're making more connections. Those synapses are becoming more complex. Gastrointestinally, they develop teeth, and on average, it's 6 to 9 months where they develop the first tooth erupts. And the stools change. Under 6 months, babies really can't absorb solids, and they should just be on formula or breast milk. Breast milk's best. After 6 months, their digestion and their ability to absorb nutrients changes, and so they get put onto some solid foods, and we'll see changes in the stool as the foods change and as their GI system matures. Renally, the kidneys are one of the last organs to mature. A child's almost 2 before their kidneys really work well. So with infants, they have an increased percent of their body weight that's water. And a neonate has more than an older infant, and an older infant is more than a child who's more than an adult. That extra body water, it's mostly interstitial, and it allows for fluid shifts to happen much more easily than it does with adults. And that is why children get dehydrated much quicker and much more easily. The other problem with our infants is their kidneys are not mature. If they start getting dehydrated, their kidneys are not able to concentrate the urine the way a child 2 or older or an adult can do. Hemopoietically, remember they have fetal hemoglobin in utero, which has a much shorter half-life than adult hemoglobin. Because of that short half-life, as it starts breaking down and they start creating adult hemoglobin, there is a natural physiologic anemia, a low H&H, that happens around 2 to 3 months. And if you remember, that also makes low H&H makes you more susceptible to infections. So we expect it, we know it's going to happen, but you can see it's not without consequences. Most infants we put on iron drops by 6 to 9 months because the fetus puts on iron stores in the last trimester of pregnancy. Between those iron stores and the iron that they reabsorb to reuse from the breakdown of the fetal hemoglobin, they have enough iron to last them about 6 to 9 months. After that time, they really need to be on if they're on formula, a formula that's iron fortified. If they're on breast milk, we're likely to give them iron supplement. That iron is put on in the last trimester of pregnancy. If a baby's preterm, they run out of iron stores much, much earlier. So they're going to be on supplemental iron very early. Immunologically, this is not mature either. The good thing, however, is in utero, a lot of the mother's antibodies cross and the baby's born with them. So the baby has immunity to those things the mom's immune to until about 6 to 9 months of age, when their own immune system takes over, but it's not very good yet. Infants' immune system is about at 60% of where an adult's is when at 12 months of age. And then integumentary, infants have very thin and very delicate skin. So, that's our problem with diaper rash. We've got to keep the skin clean and dry because it does break down easily. If you put on a topical agent, it's going to absorb much more quickly because of that thin skin. So I said we're going to look at cardiac and respiratory separately. So the respiratory system, it isn't really at adult levels for maturity till the child's about 7 years of age. Remember, with our neonate, they do periodic breathing, right? And that is normal in the first, that neonatal period. And then it becomes much more regular. Anatomically, we have a lot of differences between the infant and an adult. The nasal passages are more narrow, and if you remember, our babies are obligate nose breathers for the first 6 months of life, so it takes very little mucus in the nares to really give them respiratory distress. Trachea and chest wall are more compliant, so it doesn't take the kind of pressure if you have somebody in the ICU and you're ventilating or bagging. Bronchi and bronchioles are short and they're narrow. So infection in the upper airway, it's on an infant, it's a very short distance to get to the lower airways. And we rarely see bronchitis because the bronchioles are here, the bronchi are right there. So it goes just a little farther out because everything's so close. The larynx is shaped differently. It's funnel shaped. If you've noticed that we rarely use cuffed ET tubes or tracheostomy tubes, that's the reason, because the larynx is a different shape. We don't need that cuff. The tongue is bigger in proportion to the mouth. Alveoli are less. And so all of those anatomic differences really make our infants at risk for respiratory infections and for doing poorly when they get a respiratory infection. Cardiac, heart doubles in size in the first year of life. Newborn has a heart rate about 120 to 140, which drops to about 100 at a year. Blood pressure increases during that first year of life from an average of 60/40 to 100/50. Newborns and young infants are very susceptible to heat loss. Their capillaries are close to the surface of the skin, which means the heat in the blood just leaves the body. You and I do that when we get hot. We open all the capillaries that are on the surface in order to get that convection of heat out of our bodies. When we're cold, we constrict all of those to keep the heat in. The infant cannot do that. So they're very affected by the temperature around them, whether it be hot or cold. And so towards the end of infancy, they become much better with that thermoregulation, but it is a problem in the early stages, early months.